Dr. Manoj Chawla is a director and consultant diabetologist at Lina Diabetes Care and Mumbai Diabetes Research Center. He is based in Andheri West. He is a consultant diabetologist also working in SL Raheja Fortis, Mahim. He is the founder president of United Diabetes Forum. He is an honorary visiting faculty at the DY Patil Medical Sciences, Navi Mumbai. He was awarded the RSSDI Fellowship for the year 2017 and Fellowship of the Royal College of Physicians of Edinburgh for the year 2019. He is the principal investigator in various global MNC clinical trials, and he has got around 20 papers in national and international journals. And he will be speaking on obesity, diabetes, and COVID-19 and healing. So over to you, Dr. Chawla.
Thank you, Chairperson, sir. Thank you, Dr. Amita Biswas and Bengal Diabetes Conference for inviting me. Let me start by sharing the slides. And let me apologize that I'm actually traveling in the car and I have a very, very valid reason for the same. So our alma mater, that is TN Medical College and Nair Hospital, actually celebrates 100 years of its establishment. And there have been great celebrations the whole day. And I was glad to be visiting the alma mater with my batchmates and enjoying that moment. So there was no way I would have given that up. So I'm on the way back, and hopefully there won't be any network issues when we move ahead on this talk. So I'm going to be talking about diabetes, obesity, and I changed the topic a little because it said COVID-19, but I think it's unfortunately it's COVID-19, 2021, and maybe 22. So I'm going to be speaking about, is there really a link? And that's as specific a topic that I've been given to speak on, the link between diabetes, obesity, and COVID. I'm also, of course, depicting here the multiple waves that we may encounter with COVID. So spread of COVID-19 has reached pandemic proportions, and it represents a threat for increased morbidity and mortality, especially for patients with diabetes, obesity, and hypertension. So when we talk about the diabetes and COVID-19, so I'll speak initially on the link with diabetes and then move on to talk about and show the link with obesity. Epidemiological evidence suggests that diabetes is associated with higher risk of infectious disease. People with diabetes are at increased risk for more pneumococcal infection, which is an independent risk factor for developing worse lower respiratory tract infections. Both individuals with type 1 and type 2 diabetes have higher risk for serious infections. 6% of infection-related hospitalization and 12% of infection-related deaths attributed to type 2 diabetes. So in a large observational study, including 1,099 patients with confirmed COVID-19 infection, it indicated that of this 1,099, 173 with severe disease there had existing comorbidities. And when you look at the analysis of which other comorbidities really existed, you see hypertension as prevalent in 23.7% of the population, 16.2 having diabetes, and 5.2 having coronary heart disease. You look at more data coming in from different sections, characteristics, clinical presentation, and outcomes of patients hospitalized with COVID-19. And here we saw the most common comorbidities amongst the data from New York City, 5,700 hospitalized patients. Those having hypertension were formed 56% of this population. So hypertension was right up there, followed by obesity at 41.7%, and then diabetes at 33.8%. We also started getting a lot of data on new onset diabetes and the link between COVID and new onset hyperglycemia. So if I look at a review article, a meta-analysis published in November 2020, it showed the COVID-19 infection-related development of diabetes, and we see multiple papers which have shown that, of course, we don't have this established, whether it's a new entity, is it a different entity, is it more temporary, is it stress hyperglycemia, or more specific destruction of the beta cells, which has also been speculated. So COVID-19 infection-related diabetes and mortality, when you look at the numbers, almost 14.4% new onset diabetes in hospitalized patients. Higher rates of ICU admission, even as compared to pre-existing diabetes and those with no diabetes. ICU admission rates, if you compare for those with new diabetes, known diabetics, or those with normal glycemia, You can see 11.7% versus 4.1 versus 1.5. So those with new onset diabetes had the worst outcomes, as we have seen in the past in most cases of stress hyperglycemia having poor outcomes as compared to non-diabetics. Now, when we look at the link between COVID-19, the pathogenesis, and diabetes, we need to remember that the entire pathway of the SARS-CoV-2 is through the attachment to the ACE2 enzyme. Now, the ACE2 is presented in individuals with diabetes, and it's present in the lungs, the heart, the kidney, the enterocytes, and of course, the pancreas and the pancreatic beta cells. So we look at this paper, which speaks about the most consistent finding being a tentative causal association between diabetes-related traits and increased ACE2 expression. So based on one of the largest gene studies that they did in individuals with type 2 diabetes, almost we're talking about 89, so 8,98,130 individuals, they found that type 2 diabetes was causally linked to raised ACE2 expression, and that seems to be the strongest pathway. So when we talk about the mechanisms for increased susceptibility to COVID-19 and diabetes, well, this is often a slide that many would have seen. It's a busy slide, but it explains the entry of SARS-CoV-2 into the respiratory tract, infection of the respiratory epithelium, necrosis of the respiratory epithelium leading to pneumonia. You also look at the poor immune response. So in terms of impaired macrophage activity, impaired neutrophil recruitment, impaired interferon alphas productions from the NK cells. So all the pro-inflammatory pathways are exaggerated. The anti-inflammatory pathways get compensated there, leading to increased ACE2 expression, leading to worse infections, the problems with cardiac dysfunction, acute renal injury, and of course the worry of cytokine storm in such individuals. When you further look at the pathways which have been spoken about, well, metabolic syndrome related conditions such as diabetes together with their predisposing conditions can etiologically be linked to COVID-19 pathogens. Then again, we talk about the spike protein with SARS virus getting attached to the ACE2 site, and ACE2 becomes the host for the entry for the virus and then worsening of the infections. There's been emerging information, and when I say emerging, this is something which has emerged over the last year and a half, a lot more papers in the first 6 months of the pandemic. As we move ahead, we talk about the fact that those with diabetes are at increased risk of complications, including death. So fatality rate in patients with diabetes was much higher. We know today, we look at the Indian data also, overall fatality rate would be somewhere around 2.5%. But when you look at the individuals with diabetes, it was high at 7.3. So hyperglycemia predicts mortality. You look at the retrospective cohort from March 1st to April 6th. This is the early days in 2020 in 88 US hospitals. It speaks about COVID-19 patients with diabetes and uncontrolled hyperglycemia had a higher mortality than patients without diabetes or without uncontrolled hyperglycemia. So as high as 28.8% in those with diabetes or hyperglycemia. Those who had normal glycemia or no diabetes, 6.2% there. So hyperglycemia predicts mortality and has 4 times worse outcomes. There seems to be a direct endocrine link, and this is an interesting paper which spoke about the angiotensin and angiotensin 1 to 7, which acts on the MAS receptor pathway, the mitochondrial activator system pathways, which lead to anti-inflammatory and anti-fibrotic response, and that would be favorable to the recovery of patients with COVID. But that doesn't happen. You don't have the ACE going on to the ACE2 and the ACE 1 to 7 pathways, but rather individuals with severe COVID-19 and diabetes have an imbalance in the activation of these pathways with increased activation of the AT1 receptor and the AT2 receptors. And that increased activation of the AT1 and AT2 receptors is what is responsible for vasoconstriction, inflammation, fibrosis, proliferation, and much worse outcomes in individuals with hypertension, leading to thrombosis, ARDS, and so on. So acute hyperglycemia and mortality have had a strong link. Hyperglycemia and type 2 are independent predictors of mortality and morbidity. If we again summarize these pathways in individuals with hyperglycemia, we're talking about metabolic inflammation. We're talking about possibility of cytokine storm. The fact that patients with diabetes and severe hyperglycemia will have impaired immune response and impaired healing, and the fact that the dysregulated immune response results in aggravated and prolonged lung pathology, and of course, the chances of higher viral loads. So diabetes as a risk factor for COVID-19, this is the statement from the IDF, which spoke about two main reasons for why individuals with diabetes have high risk: functional immunocompromised state associated with diabetes, favorable conditions like hyperglycemia, promoting more viral replication in such individuals. I'm not speaking about the management of diabetes in patients with COVID-19. I think that's a huge topic in itself. But I would bring to forth the fact that the therapeutic aims is to keep the plasma glucose concentration largely between 70 and 180, HbA1c closer to 7. Where required, you would use an FGM or a CGM. The time in range to be tried and kept more than 70% and to avoid hypoglycemia. The principles of glycemic management for COVID-19, good glycemic control is essential. You could tailor the strategies, you could use orals where possible, you may move to using injectables, have the need to use steroids and more insulin. All of that is fine, but at the crux of it is good glycemic control. So management of diabetes with patients with COVID-19 will actually be part of two aspects, whether they are on oral anti-hyperglycemic medications or those on insulin therapy, and then you will have different strategies for the same. What you need to consider for your pharmacological management is the age of the individual, the severity of COVID-19, the presence of cardiovascular comorbidities, and of course, keeping in mind the need to avoid hypoglycemia. Your targets for fasting in mild young patients, it could be aggressive 80 to 110, slightly older or those on steroids 110 to 140, and severe or critically ill 140 to 180 as the targets for fasting. And the postprandial targets are correspondingly listed here, as we can see. So when we look at an overview of the management, well, anti-hyperglycemic agents that can cause volume depletion or hyperglycemia should be avoided. SGLT2 inhibitors have kind of been implicated in the DARE study, and they've been found okay and safe to use, but no real benefits. Dosage of oral anti-diabetic drugs may need to be reduced. If it is necessary to stop metformin, then an alternative treatment needs to be put in place until you can start metformin. You just don't leave the patient alone. Patient on oral diabetes treatment should have their glucose testing done on a regular basis and monitor the sugars. Guidelines for insulin use in such patients: glucose levels more than 180, increase the insulin dose. Testing should be done more frequently, especially if the sugars go beyond 270. You may want to check every 4 hours or advise your patient to do the same. If the blood glucose persists to remain more than 270, you may want to have a look at the urine ketones. And if there is presence of ketones, ask your patient to get in touch with you or any other healthcare provider. I move to the second part of the section quickly, which is talking about the link with obesity and diabetes. Several hundred studies provide evidence that BMI is a strong linear risk factor for severe COVID-19 outcomes, with recent studies suggesting 5 to 10% higher risk for COVID-19 hospitalization for every kilogram per meter increase in the BMI. The genetic data concur with hazard ratios increasing by 14% for every kilogram per meter, every single BMI point. BMI to COVID-19 links differ markedly from prior BMI infection associations and are further supported by multiple biological possible pathways. The excess adiposity appears to be important. Some modifiable risk factors for adverse COVID-19 outcomes are present through this aspect in multiple ethnicities. And it's imperative that medical systems worldwide meet this challenge by upscaling the treatment for prevention of obesity and using treatments where possible. So this is a study which spoke about 334,000 individuals in England during spring of 2020, which showed how increasing BMI was increasing the chances of hospital admission. So for every 10,000 people, those with stage 2 obesity and a BMI more than 35 had the highest chance of hospitalization as compared to those with normal BMI between 18 to 25. So obesity contributes to metabolic derangements, which could be linked to ectopic fat in the liver or pancreas, overall poor vascular health, greater thrombotic potential, and the adverse lung and renal functions in general in people with obesity. There may also be indirect links between obesity and COVID-19, such as an adverse diet-induced microbiome impact on the immune deficiency. So when you look at the potential mechanisms, you could have systemic factors: increased cytokine inflammatory production, a compromised immune system, increased insulin resistance, overall reduced heart function in an individual with obesity, decreased tissue perfusion, and overactivation of the RAS system. Some biomechanical factors which become important: reduced lung compliance, reduced functional residual capacity. So they're already at a higher risk. Increased esophageal and gastric pressures and increased chances of obstructive sleep apnea and hypoxemia. So all of this is increasing the vulnerability of an individual with obesity to SARS-CoV-2, increased chances of severe course of the COVID-19 infection, and unfortunately, higher mortality rates. And when you look at the current evidence, there is evidence through epidemiological studies. There has been some Mendelian randomization genetic studies, which have again shown the link with obesity. There have been no real great intervention trials, but small studies looking at subsets of patients undergone bariatric surgery who had their BMI reduced by 12 points, found their risk of hospitalization to be 69% lower than those who were continuing to be obese. And then there have been some biological possibilities, as I explained earlier. So obesity and COVID-19, what makes the obese host so vulnerable? You'll appreciate the higher incidence of hazard ratio in those with the higher BMIs. Look at the certain different studies, those with more than 3.35, you're seeing a 7.36 hazard ratio against those with obesity. At studies from Fatality earlier, with more than 40 BMI, you're seeing a hazard ratio of more than 2.45. This seems to be an explanation as to what's going wrong. An obese host, there is chronic inflammation, there is immune system dysfunction, ACE2 receptor overexpression, increased viral entry and increased viral load and spread, more inflammation, insulin and leptin resistance leading to impaired immunity, and severe disease and poor clinical outcome. If I further look more closely into the same pathway, it explains the more pro-inflammatory adipokine presence. The anti-inflammatory adipokines are reduced largely because of the excess fat, which leads to a substantial alteration of the cellular architecture of the adipose tissue. That's responsible for this altered milieu of the inflammation. So elevated fatty acids, reticulum stress, hypoxia, and mitochondrial dysfunction contributes. You have indirect factors as well. You have the lockdown consequences, worse diets, decreased activity. You itself have obesity as a causal risk factor, as explained through multiple pathways. And the fact that obesity very often is linked to comorbid conditions like diabetes, chronic kidney disease, liver disease, and so on. So really the time to upscale prevention to prevent obesity. Now, I found another interesting link between obesity, and I will emphasize only on the impact that we see here. The biological and social factors I've already spoken about, but learnings from these H1N1 studies showed increased viral load, increased shedding time, reduced immunity from infection, decreased vaccine efficacy, and increased chronic disease progression. I must say we have no reports as of now about reduced vaccine efficacy in the obese individuals or those with diabetes, but these were some of the learnings from the previous pandemics. The final point that we need to understand and take home is SARS-CoV-2 causes beta cell damage, possibility of cytokine storm, possibility of admission hyperglycemia or worsening metabolic control in patients with diabetes, or chances of new onset diabetes. All of this in individuals with obesity, worsening inflammation, more pro-coagulatory and pro-thrombotic state, older age, hypertension, and presence of renal disease. You have these as a background, there are chances of much, much poor outcome. So let me conclude by saying type 1 and type 2 diabetes are associated with increased risk of COVID-19 related hospitalization and severe outcomes, including mortality, particularly in people with poor glycemic control. Recent data have suggested an increased risk associated with development of new onset diabetes following COVID-19 hospitalization. However, longer term follow-up data will determine if this kind of diabetes is more permanent. And several hundred studies provide powerful evidence that BMI is a strong linear risk factor for COVID-19 outcomes, with recent studies suggesting 5 to 10% higher risk for COVID-19 hospitalization for every kilogram per meter square increase in BMI. With this, I thank you for inviting me here and hand it back to the chairpersons. Thank you so much.